So plaques are dangerous for two reasons. One, they narrow the artery and can give you angina. But the second one, which is more important actually, is cracking, when the plaque cracks. And you all know that I give my talks on why the plaques crack. They crack because of inflammation in the plaque. The plaque is almost like a pimple, and it bursts on the inside of the artery. So you need an anti-inflammatory lifestyle. You need an anti-inflammatory diet so that your plaques don't crack and cause a heart attack. So when the plaques form in the arteries, you definitely want to stabilize them. You want to go on the anti-inflammatory diet, anti-inflammatory lifestyle, which we'll talk about. That's a whole separate talk. But if this artery narrows down, and now let's say that this plaque healed itself, the guy didn't even know about it, but now he's got a blockage here. At what point does it reduce the blood flow? Because today's talk is about FFR. When this blockage, on average, is greater than 75% narrowed, that's when the blood here will be diminished. Now, when the blood starts getting diminished, the patients will, one, they may get chest pain, pressure, tightness, heaviness. When you walk, you climb stairs, you exercise, you get a pressure, tightness, or you may get short of breath when you walk, or you may feel palpitations. Or worse, you may feel nothing. The worst part is 80% of people who have a blockage more than 75, they don't even have chest pain. So not having chest pain or pressure doesn't mean anything. It just means that you don't have a proper angina warning system. The guy who's getting chest pain when he's exercising, he's lucky because he'll go to his doctor complaining of chest pain, and this will come to attention. The tragedy we have in America today is that many people have this blockage, but they're not getting chest pain, so they go undetected. And then one day, when it completely shuts down, they're getting a heart attack. Plaque should not rupture. Plaque should not be growing. You can have plaque. We can stop them from growing anymore. We can stabilize them. And if the plaque is more than 75%, it restricts flow. Why would I care if he's not having chest pain, right? Why would you care if he's not having a chest pain? So what? Well, the problem is this piece of muscle here, when it's not getting enough blood supply, you can run into an arrhythmia, and the muscle will also not work very well. So if it's an arrhythmia, let's say that this patient runs up the stairs, he can get an arrhythmia because the muscle is not getting enough blood supply. So suddenly his heart goes into ventricular fibrillation, he passes out. That's sudden death. Doesn't wake up until the paramedics come. And even then, he may not come out of ventricular fibrillation. So we consider about arrhythmias. Number two, muscle damage. That when this ejection fraction, the pump, gets weak, the patients may complain of shortness of breath. They may be going into congestive heart failure because that muscle is not getting enough blood supply. So we see a lot of patients who come here, they have shortness of breath, and the ejection fractions are not so good. The heart is weak. Not damaged, it's not dead. All it is blockage. And we improve the blockage, and the muscle starts working again, and then they're fine, right? So we are concerned about blockages because we don't want them to get an arrhythmia, and we don't want the heart muscle to get weak over time. So it's important to know whether you have what is known as a flow-limiting lesion. This is a lesion, right? You want to know whether it is flow limiting. Is it limiting my flow? You have to know that. So I do calcium scores on patients, and if I see that they have calcification buildup, then I want to know whether it's doing this, which narrowing it, or is it just sitting in the wall? How do I do that? I do a stress test, right? That's been traditionally what we do. So when you do a stress test, then you can tell by EKG whether So all of a sudden, he gets ST depression on his EKG. So they say, aha, you're not getting blood supply to your heart muscle. You flunked your stress test. You need further testing. That's one way to do it. The other way is a nuclear test. So when you do a nuclear test, what you do is injecting the radioactive material, and you can show on the stress test that this artery is not getting enough blood supply. But this artery that's on the side here, that's getting plenty blood supply, and the one at the back is getting plenty blood supply. So you can see that on the nuclear stress test. So that's how you tell if someone has a blockage or not. So they have calcium. It may be sitting in the wall, or it may be narrowing the artery. You don't know. You want to know whether the artery is narrowing inside or not? The dangerous stuff, you need to do a stress test. You look at the EKG portion, and you do a nuclear stress test. Right? Now, this is how we were doing until some years back. Now we do angiography and CT angiography. So now I'm going to come to that. So on cardiac cath, you're injecting the artery. But that's an invasive test. And if we see a blockage, and it's a tight blockage, you usually know that this thing's causing a problem, right? These days, we also do CT scans. So let me now introduce you to angiography. Okay, angiography. Angiography means you're taking a picture of the artery. How? You can go inside from your arm or from the leg and shoot the dye into the arteries and see the blockages. So now runs the problem. So here's an artery, just like before. And I'm putting dye on the inside. So I bring my catheter here and I'm shooting the dye into the artery. Am I going to be able to see what's on the outside here? No. I'm only seeing the inside. So it comes here and it might be narrowed like this. It might be narrowed like this. That's on the angiogram. And I look at that and I say, aha, this is about 60% narrowed. And I might want to put a stent in you to open that blockage up. But is that an accurate measurement? Is it an accurate measurement on angiogram? And my answer is no. Unless it's really, really tight, very difficult to know whether this is flow limiting or not on the angiogram. On the angiogram, you just see there's a blockage, but you can't tell whether it's actually limiting flow or not. You need a functional test to tell you whether it's actually limiting the blood flow or not. That is why before we do angiography, we always do functional testing. That's a golden rule. You must know whether the blockages are just sitting there and maybe they're not obstructing flow. Maybe it's only 60%, maybe it's 70%. You've got to do a stress test, or you got to do some other form of testing to know that it's a flow-limiting lesion. Angiograms don't tell you whether it's flow-limiting or not. That just tells you have a blockage. And that's the tragedy. Because what's happening today is we do angiography without functional testing. 3 arteries. He's got a blockage in all 3. Oh yeah, 3-vessel disease, bypass surgery. But out of those 3 arteries, 2 of them may not be having a flow-limiting lesion. How would you know that? How would you know? Because look, there are so many of my patients that have 3-vessel disease. Blockages in all 3 arteries. You got to know which one is causing a problem and which one is not. Otherwise, you're going to take a photograph and find 3 blockages, 1 in each artery, and say, okay, you need 3 stents or you need bypass surgery. And that's happening all the time. So a patient comes in, let's say a diabetic patient, he's experiencing a little bit of discomfort, comes to the doctor says, you know what, you've got all these risk factors, let's just go straight to cath. You cath the patient, you find blockages, next thing you know, he's getting angioplasty or he's getting bypass surgery, without having known whether those arteries are reducing blood flow or not. So then you might say, well, now these blockages are being bypassed, so he's going to live long. No, not necessarily. Because if it was not reducing the blood flow in the first place, putting a bypass to it, it's not going to make you better. If you're already getting plenty blood flow down that artery, and now you put a bypass to it, Or you put a stent in here. What benefit did you get out of that? You're still getting plenty of blood flow getting through it. What did you do now? That's the question. That's the problem that we are having. You see, coronary artery disease is very pervasive. It's out there. People have it. That's a whole different topic that we're going to talk about in my future lectures too, and those that I've already done on why people are getting blockages. But the problem is that those who have the blockages are not being adequately diagnosed as who really needs revascularization, who does not, whose arteries are really clogged and whose are not clogged. And all they need is a prevention program to prevent it from cracking and getting worse. If it's not limiting your flow, leave it alone. Putting a stent in a blockage that's not restricting blood makes no sense. So do I have studies to show you? I do, and I'll show them to you in a minute. That if you do put a stent in a blockage that's not really needed, because there's plenty of blood going down there, but let's just get rid of it. Oh, it's sitting over there, let's just stent it. Is that patient going to live longer? In fact, he's going to live less. Because now he's going to get the complications of stent thrombosis, which can occur in 1 or 2% of patients, stent restenosis, which is scarring inside the stent, which can occur in up to 5 to 6% of patients, even with drug-eluting stents. So you've taken somebody who this thing was not causing any flow limitation, and you put a stent in them, and you made them worse off than they were before. No benefit. See? So just because there's a blockage doesn't mean you need to go in and revascularize it, either surgically or percutaneously using angioplasty. You got to know whether it's actually causing a flow limitation or not. And that's why we need better testing. So in the cath lab, when we do angiography, when I do angiography, let's say that you came to the cath lab in the hospital, came to me because you're having some chest pain and they said you need a heart cath, possible stent placement. I'll do the angiogram and I've got no stress test to go by. All I have is the angiogram. Then this is what I would do. Okay? Here's your angiogram. Here's your right coronary artery. This is your circumflex artery going to the back. This is the artery in the front. And I bring my catheter from the arm, usually, and I'll bring it right up here like this and inject the dye, and then bring it over here and inject the dye. So I'm going to see where the blockages are. Okay? Now, I told you he might have a blockage. So let's give him a blockage. It's right here. Got a blockage. So, oh my gosh, he's got a blockage. Maybe this is a problem blockage, right? So this is where I do an invasive FFR, Fractional Flow Reserve, in the cath lab. FFR. How am I going to do this? It's very easy. Those who are all engineers here should know. I take a wire, a very fine wire. It's a pressure wire. It measures pressure. And I bring it in my catheter, slide it here, and I slide it through the blockage, and I position the wire there. Got it? And I'm measuring the pressure difference here versus here. Makes sense, right? If there is a difference in the pressure here versus here, that means this lesion is capable of decreasing blood flow. So we didn't have this technology, but now we have this, and we've really perfected this. This is called Fractional Flow Reserve. So it is looking at the ratio of the pressure here versus here. I maximally vasodilate this muscle, which is, I don't think you should get involved with those terms, but basically I'm giving adenosine to maximally vasodilate the arteries here, and then I'm looking to see if I can create a gradient across that lesion. So if I'm creating a gradient, the pressure here is higher than here. And if my FFR is less than 0.8, 1.0 being normal. Now I know I'm restricting my blood flow. Now I know, yes, this lesion needs to be stented because it is capable of decreasing blood flow. If the FFR is greater than 0.8, that blockage is not flow limiting. I mean, it's got a blockage. I can see it, but it's not flow limiting. I'm getting a physiological data. See that? Because the other alternative would be stop, send him out for a stress test, bring him back again if he fails his stress test. So this way we can do the FFR in the cath lab itself, right there on the spot. So this is how FFR started in the cath lab. So in the cath lab, I can determine if he's got a blockage, what's its FFR, and let's say he's got another blockage over here, and maybe he's got one over here. I can do the FFR for each one. So I take that wire, I slide it down each one. Now, why is this so important? Because let's say this gentleman had 1, 2, 3 blockages. And if I didn't do the FFR, I'm going to say he's got 3 vessel disease, call the surgeon, let's operate. Do you get it? And a lot of that is going on. You have to have precise data. Without data, you can't just do things. These. I told you, if I put a stent here, here, and here, and they were not needed, the stent can thrombose. You may get a complication of bleeding from medications that you're supposed to get, or you may get restenosis. Restenosis is scarring inside the stent. So whereas you could have continued, and actually what happened is that you just had something bad to eat and having indigestion. That's what really brought you to the hospital. And you end up getting a stent. Do you see the danger here? That is why FFR is so fantastic. You take the wire, put it down across each lesion, and you're fine. So have studies been done to show that if you go with the direction from the FFR and then to the stent, so FFR directed stenting, does that lead to better outcomes than if you just angiographically look at it and stent it? The studies have been done. So in those studies, they took the patients who had angiographic data like this, 3 blockages, and compared them and their outcomes to those who had blockages, but they only got stents according to the FFR. So stenting versus a stenting FFR directed versus angiographic direction. Which had better outcomes? Better outcomes were those who had FFR. Because you're only doing the lesion that really were blocking and restricting the flow. So that data is very solid data now. So we know this data. So having this knowledge now, am I going to take you to the cath lab every time to put that wire inside your artery? It's invasive. So is there another way that we can do this? Is there another way? I told you about the stress test. The stress test doesn't tell you about that particular lesion. It just tells you that this portion of the heart is not getting enough blood supply. So patients often tell me, well, what's my percentage blockage? I failed my stress test. All I can say to you is that the front of the heart is not getting enough blood supply. It could be from a blockage here, 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 or here. I don't know. And how tight it is, I don't know. All I know, it is probably more than 75%. It could be 80, it could be 90, it could be 95. It could even be 100% with collaterals. All I know is that the front is not getting enough blood supply. So you still need an angiogram. You got a positive stress test, you still need an angiogram. You need anatomical data to see where the blockage is and what to do with it. Okay. So there you go. So this is helpful in the cath lab. When I'm inside the cath lab, that's very helpful because I'm already there. I'm going to do FFR. So is there another way? So let's look at CT scans. So you all know that we are doing CT scans now, right? So let's talk a little bit about CT scans and how that has changed what's going on. In a CT angio, you're injecting dye in a vein and it's going into the arteries. And once again, it's going into each artery. The dye is going there and you're doing a CT scan and you can actually see the blockages. But we have a problem. Here's the artery. And I'm going to draw some plaque in here. We've got some calcium buildup, a nice big chunk of calcium here, okay? Look, it's on the outside. A little bit is going on the inside too. Let's give it a little bit more. Let's give it like about a 30% blockage, okay? So the CT scan shows you this. But the problem is when X-rays go through calcium, it casts a shadow. So you overestimate the blockage. So when you're looking at the CT angiograms, you say, this guy's got a 50, 60% blockage. Well, what is it? So we have noticed that with CT angiograms, it tells you that there's a blockage, tells you there's calcium, doesn't tell you accurately what the percentage is. And if you read your CT angio reports, they'll all be between 40 and 60, 60 to 70%, but they're never really that accurate because it's a visual estimation. Okay? It's a visual estimation. And it can give you an overread on the stenosis. It's called blooming artifacts. But it doesn't really tell you functionally what's going on in that artery. It doesn't. You need more valuable information to know that. So CT scans are extremely helpful. First of all, if your CT scan shows you have no calcium, you don't have coronary disease. That's why I like CT scans. That's why I like coronary calcium scores. So the thing I do is I look at coronary calcium. So let's say you came to me and you're having some issues and you're concerned that I got hardening of the arteries. My father had a heart attack. My brother just had bypass surgery. Do I have a problem? I'll get a calcium score on you. That's the first thing I'm going to get on. Because it's so easy to do. It's a low-level CT scan looking for calcium in the walls of the arteries. If your score is 0, do you have coronary disease? You don't. You're done. Go home. You're done. Stop eating that garbage because that's what's giving you heartburn. Follow my videos. So that's why I like calcium scores. Now, if your calciums come back positive, yeah, you got calcium. 0 to 100 is mild. 100 to 400 is moderate. More than 400 is severe. Then I'm going to say, okay, this is a problem. We can either go to a stress test to see if these blockages are actually causing you a problem, or we can do a CT angiogram. So we do the CT angiogram, and the report comes back saying, 50 to 60% blockage right there. Well, 60 could be 70, this could be 40, so it's too wishy-washy. I need to know whether that's actually capable of reducing your blood flow or not. So now, once again, comes FFR. So we didn't have this technology, but the technology is now there, where you can actually then take the CT angiogram and send it out to California and have AI look at it. AI has some uses after all. And that report may come back and say, this is a flow-limiting lesion. The FFR on this lesion is 0.6. That's abnormal, right? Totally. It's abnormal, 0.6. So that means, yes, this lesion needs to be fixed. You need a stent to this one. But this other artery that was here, branch, big branch also here, and it also had a blockage in it. And the FFR, it looked like it was about 50%, but the FFR on this one was 0.9. And then the right coronary artery also had a problem. There was a 50% blockage there also, because remember, coronary artery disease is a systemic disease. It's not just a focal disease. If you've got blockage in one artery, you have blockage in another one as well. All your arteries are going to have some degree of plaque. There's no such thing as single vessel disease. If you look hard enough, it's in all three arteries. So this report would come back saying 50% here, 50% here, 50 to 60% here, but the FFR is only abnormal here. So what does that mean? That means you go in and you fix this blockage, if you can fix it with a stent, and you get rid of that blockage. So now the flow is going to be restored. You've done something good. Otherwise, you're going to say, all these other blockages, you're just better off doing bypass surgery. So focus in on the blockage, the one that's functionally important, FFR, fractional flow reserve, has to be the mainstay of future. We have to look at functional testing. Either you're going to do a nucleus test or you're going to do a CT scan. That's going to tell you what's going to go on. So the way we're working our patients right now is we're still doing a lot of stress testing too. So I'm just going to give you a little background on the physiology of what happens. Here's the muscle. When you're exercising, you vasodilate. All these little blood vessels, they open up. And when you're running, jogging, when you're doing any kind of exercise, so at rest, there may be plenty of blood going in, but when this vasodilates, that's how you get more blood coming down. Because you're vasodilating. When you exercise, you vasodilate. So you're getting more blood that's needed because you vasodilate here. So you're drawing more blood into the heart muscle. And that's how we measure FFR in the cath lab. We give a vasodilator into the artery, it vasodilates all of this, and then you create a gradient, a difference in pressure between this and this. So by doing FFR on these patients, we are going to be able to identify lesions that really need to be fixed and lesions that need to be left alone. So my particular interest is to leave the blood vessels alone. That's what I like to do. If you have a flow-limiting lesion on FFR, I'll intervene in it, but I only want to put in what's necessary. Only the bare minimum needs to be done, because the biggest problem is all these other plaques. Why am I telling you that they are the problem? Because in all my experience, I've seen the rule of 70s. I'm going to explain the rule of 70s. 70% of heart attacks occur in blockages that are less than 70%. I mean, suddenly this thing cracks and it became 100. So it was less than 70 the day before. Yesterday he could climb Mount Dora, he had no problems. How come he's having a heart attack today? Because the plaque cracked. So I'm more interested in taking blockages and stabilizing them. Try to make sure that they're not going to get worse in the future. Keep them stable as well. You can shrink these a little bit. You can't get rid of them. If your calcium score is 1800, it's not going to go down to 500. But what you can do through an anti-inflammatory diet and anti-inflammatory lifestyle is to make sure that that doesn't get any worse. And number two, it doesn't crack. Because if it cracks, a blood clot will form on it. So that's the whole point. The point about doing that FFR is to tell you that fix only this one, leave the rest alone. The rest are to be managed systemically, physically. Diet, sleep, stress, toxins, nutrition, fixing your hormones, fixing your gut microbiome. That's what's going to take care of these blockages. Not a stent. Because these days what's happening is that most people think that you have a blockage, then you're going to get a stent, and then you're going to be on aspirin, and maybe some Plavix, and then you're going to get a statin, and you're done. And I'm saying to you that you may need the stent, but what you really need is a big workup as to why you got the plaque, and what are you going to do to stabilize the plaque? What did you do? What did you do? Well, you got to know what made that plaques happen in the first place. And most plaques occur because of inflammation. Inflammation. And this inflammation comes from what? Inflammation is when you're attacking something foreign. What are you attacking that's foreign? It's all you. How can you be developing a pimple on the inside of the artery? It's full of inflammatory materials in here. There's T cells in here. There's B cells in there. And there's macrophages that are dying in there and releasing the calcium, and that's all that calcium inside there. What it is inflammatory. And nobody has really come up with a solution or answer as to where that inflammation actually comes from. They'll say it's inflammation, but they don't know where it's coming from. And I'm going to tell you tonight what I think. I think most of that inflammation comes from your gut. Because your gut is the difference between what's outside you and what's really you. You see, you got to understand why your body is mounting an immune response against what. So it's a separate topic. But these days I look for gut sources of inflammation, where you have either what is known as gut permeability issues because you have food sensitivities, or you have a dysfunctional microbiome. Your gut microbiome, the bacteria in your gut are not right. And I'm saying this over and over again, that these patients, if you sit and talk to them long enough, you'll find out that they all have a gut problem. And this is what's causing the translocation of lipopolysaccharides from the gut into the bloodstream, which then get taken up by the LDL molecules, the bad cholesterol molecule, as you all know them as, and create what is known as small, dense particles. These small, dense LDLs tell you there's this inflammation going on in the body. And these molecules get taken up by the macrophages. And then the macrophages engulf them all. And of course, these particles also activate the endothelium. So it activates the endothelium. So the endothelium gets denuded. The glycocalyx gets destroyed. And then these molecules come along here. And the white cells come here, the macrophages, and they get stuck to that area over here. And then they go inside and they die in the wall, and now you're getting a plaque right there. It's all to do with inflammation. So the looking for sources of inflammation is very important. It starts with the gut. It also starts with your lifestyle. It starts with how much you're sleeping, how you're stressing, whether you have parasympathetic or sympathetic nervous system activation, whether you have heavy metals in your body. All these things cause these formations. So once they form, then you need to know whether it's actually flow limiting or not. And if it's flow limiting, then you do an intervention. So you can do stenting or bypass surgery. But if you reverse engineer every patient, you got to reverse engineer every patient with coronary disease. Otherwise, you're just taking care of the stent or the bypass and you've just stopped. Go back. You got to reverse engineer. Reverse engineering is very important. Okay, so he's got this blockage. Why does he have it? Let's go back. Let's take a look at this guy. He's got hyperinsulinemia. What does that do? That causes nitric oxide depletion, promotes atherosclerosis, promotes obesity, promotes fatty liver. So he's got pre-diabetes. He's got a very high insulin level. Wow, that causes the formation of atherosclerotic disease right there. It causes high blood pressure as well. All that denudes the endothelium, that causes problems in the arteries. So it's at high insulin. Sugars, of course, high sugar also destroys the lining of the arteries because it glycates them and destroys the glycocalyx, which is the protective lining on your arteries. They get destroyed as well. So he's got a hormonal problem. He's got hyperinsulinemia. Then you look at his fatty liver and say, there's something wrong with this guy's liver. It's a seat of metabolism. What's going on? Why did he get a fatty liver? Oh, he's getting stuff that's coming up from his gut and causing a fatty liver. You chase those issues and chase the gut bacteria and try to fix that, because that will stop this onslaught of what I call metabolic endotoxemia. So you reverse engineer, get back to prevention. Look for all those risk factors. But the exciting thing today I wanted to introduce to you was FFR. Because you know people who have blockages. You know people who have positive calcium scores. And they need to know what their FFR is. So if they're not going to do a stress test, they should at least get a CT angiogram. And on the CT angiogram, you can tell that, yes, he's got blockages here, which lesions are actually causing blockages. There's so many patients that I see where their CT scan showed a lot of calcium, they pass their stress test, and their FFRs are all okay. So what are you going to do with those patients? They have a calcium score of 1800 and they're walking around feeling great. Stress test is fine, no problem. CT angio, no problem. They just have a lot of calcium. Well, they'll live with that calcium, just don't die from the calcium. So stabilize it, don't let it crack. Now, when it cracks, a blood clot forms. So a heart attack is just as much inflammation causing the plaques to crack, and key point is also hematological. That means if your blood is very thick and sticky and it's hypercoagulable, you're going to get a small crack and a big clot. Got it? You see, some people can crack to the same extent, but if his blood is clotty and you have a high viscosity because your hemoglobin is really high, let's say, or you have lipoprotein little a, which will predispose you to larger blood clots, then you are going to get a large blood clot. She may rupture and just get a small little blood clot and it'll heal over. And she's done. And the rate of progression of disease in you is going to be far more than her. Because every time you both crack, she's just getting a small clot and it's healing over. And just the percentage went up by 5% or 6% only. In him, every time it cracks, the stenosis is getting progressively more and more and more because larger clots form in it. Because when a clot forms, it then gets covered over. So my point is, when you're looking at the workup of these patients, you need to look at inflammation, which I told you about already. You also need to look at your blood. Is your blood clotty? I look at that. So you've got to determine whether your blood is predisposing you to large blood clots or not. That's why we do the advanced lipid panel, we do blood counts, and that gives us a lot of information to predict what will happen to you. How rapidly is your calcium going up? So let's say you got a calcium score this year of 1800, and next year it's 2500. You have a problem. You got the burners on. You're cooking inside. So you need to find out what's going on in here. So there's so many things we look at besides it. Okay, I told you about the inflammation. I told you about the blood clots. There are other things also. Nutritional deficiencies cause this to progress also. Bad food, all the processed food, all the Maillard reaction, which is all these aging products. When you take, for example, your food and you excessively brown it and excessively cook it, all those molecules get absorbed into your body and they cause hardening of the arteries as well. So it's not just what you eat, it's also how you're cooking your food. Kill your food and then it kills you. You got to be careful how you cook your food also. So it's not only what you eat. And of course, those are all topics of discussion for another day. But it's what you eat, how often you eat, and what you eat, how did you cook it, and what kind of oils did you use in it? So how easily oxidized was it? It gets really complicated. Oxidation is really important. So if you're eating a lot of vegetable oils, for example, you're going to get a lot of oxidative stress in your body. And that oxidative stress is going to hurt your arteries big time. And it's going to cause acceleration of plaque formation. There's a lot of things to look at. So we do a deep dive into all these things. So all that doesn't sound very glorious, but putting a stent in somebody or sending them for bypass, right? You're now a real doctor. But I'm saying to you, a real doctor is not that. Some of my technician friends who help me when I'm doing angioplasty, they can probably do it on their own and probably do a better job than a lot of others that I know. So what I'm saying to you is that a great cardiologist is not one that can only do a great stent. Yeah, you hope he does a good stent too, or a great surgeon that does great surgery. But the better one is the one that's going to make sure you don't get progressive disease and that you don't rupture your plaques and that you will die with your plaques, not from them. And by the way, the same processes that I talk about here about inflammation and lifestyle also reduce your risks of having a stroke, blindness, kidney failure, some cancers, degenerative joint disease, neurodegenerative diseases of the head. So there's so many benefits because ultimately it all comes down to inflammation. Our lifestyle will cause coronary disease and all the other diseases that I just mentioned all come down to our lifestyle. So we need a lifestyle change. That's what we all need today. It's a lifestyle change. So we talk about the parasympathetic nervous system, and I teach patients how to hack the parasympathetic, because parasympathetic is the healing aspect of your system. If you're only sympathetic all the time, you're going to get blood clots. If I take some adrenaline and shoot it into you, you're going to make blood clots right now. Your platelets become really sticky and jittery. See what I'm saying? Because you're ready for war. Fight, flight, flight. So everything impacts my arteries. And whether I'm going to rupture and whether I'm going to get a big blood clot on it or not. Depends also on my demeanor, how I am. Whether I'm happy or joyful, or do I feel stressed? Or do I feel angry? Because how's my body interpreting what I'm living right now? It's going to determine what's happening here. Because my entire physiology changes. See? So it's fascinating. I think coronary artery disease is linked to everything else. And that is why we are very, very aggressive in this field. And all of you are here because you're interested to prevent heart disease. Yeah. Today's lesson is that most of you don't need a stent. Most of you are not going to need a bypass. That's only for patients who have a tight blockage. Either they're having symptoms or they have objective evidence of lack of circulation. If you don't have objective evidence with a nuclear stress test or EKG changes, then you must get some form of testing. If it's an angiogram, you do an FFR before you stent. Or you do a CT angiogram and you look for an FFR. And if the FFR is high, then I'm much more likely to say, you know what? You need to come to the cath lab with me because now I need to go in. And when I do my angiograms on those patients with positive FFRs, I'm doing my own FFR in the lab as well. So I measure the FFR, put the wire down, make sure this lesion does really need to be fixed, and then fix it. And the outcomes are so much, much, much better than if you just blindly go in and put stents in. Remember, if I put a big stent over here, and now there's only a short bit of artery over here, and let's say, God forbid, you re-narrow this whole segment here where the stent is, how are you going to bypass this patient in the future? See, stenting is not that a great solution to everything because you need a nice piece of artery here to put a bypass into. But if there's only a tiny piece of artery left and you bypass into that, the bypass will shut down because there's no flow. So stenting changes your future and your future options as well. That is why we must make sure the FFRs are done and only open up the blockages that are causing a problem. See, you do an angiogram. The beginning of the artery may have a narrowing. There's a moderate area here. But let's say that there's a really tight one here. Then just put a stent here. And then you can measure the FFR across this one. What often happens is that they see that there's a 50% here, there's a 90% here, right? But if you put the wire down and you do a pullback FFR, that tells you there's a drop across this one. Oh, no, there isn't. This one, oh, yeah, there it is. I saw the block. I saw this. I saw the pressure change. Then you put a stent in this one and not this one. On the CT angio, when you get the FFRs back, I've already seen that on many patients. Now, what happens is the FFR here may be abnormal. It may not accurately tell you exactly which blockage, but on the angiogram, when I'm doing it, I can accurately pull back and see exactly which lesion is causing the drop in the pressure on the FFR, and stent only that particular blockage and leave the rest alone because it's not flow limiting. And then comes the hard work. Here's your diet. Here's your lifestyle. This is good. This is your nutrition. This is going to be your metabolic workup. These are the prebiotics or whatever I'm going to give you. This is your insulin, how we're going to manage your insulin resistance. This is going to be your sleep pattern from now onward. This is what you're going to do to hack your parasympathetic nervous system. This is what you're going to do. And you talk about these things, get the patient through everything, and they'll be doing great. So I'm going to stop right there because I know we started real late. But if you've got any questions on FFR or anything to do with coronary artery disease, I'm happy to take a few questions. Yes, sir. Very good point. So I'm going to show you how we do that. So remember, we're not stressing the patient at that time. They are lying down. Even on the CT scan, it's only a matter of literally seconds that you're doing it. So there's no fluctuations in your blood pressure, but with each heartbeat, it's fluctuating, right? So, okay, so bear with me here. This is an artery, and I came in with my catheter. I'm going to draw a catheter inside. It's a hollow tube. And inside that catheter, I have my wire, the one that's going to measure the pressure. And here is the blockage. And I want to see what it's doing here, right? Right? So what it's going to do is I'm going to measure two pressures. One pressure is going to come from this catheter, which is measuring the pressure here. You see this opening here? It has an opening here, right? My hollow catheter. Because this wire doesn't take up all the space inside my hollow tube, my catheter. So there's a pressure reading here that I'm going to be getting. So with each heartbeat, I'm getting a pressure. Now this wire is measuring its own pressure. And that pressure is going to also, at the same time, simultaneously, it's going to go. Okay. So I'm getting two simultaneous pressures, and then the computer calculates for me what the FFR is. Because if there is no change in here, the pink one should be the same as the blue one. Identical.
The calcium reading is mostly in the heart area, because that's where
in the wall of the artery. The calcium score is in the wall of the artery. See, when these macrophages that cause the inflammation, when they go inside the wall of the artery, they die there. And they liberate all that calcium. And that's what the calcium is, the graveyard of inflammation. It's like scarring. If you have a lot of calcium, that means at some point you had so much inflammation in that artery that it left behind all the scars. Now, scars are scars. Let it stay a scar. How? If you have a scar, you don't keep opening it up, right? You stabilize it. As long as that scar doesn't get any worse in the future, you're fine. Don't let it crack. Don't build up more scar on it. Leave it alone. So the calcium is in the wall of the artery. It's in it. It's in the wall. And it can negatively remodel the artery. That means it's now encroaching into the lumen, or positive remodeling, it's encroaching onto the outside of the lumen. of the artery. Yeah, but calcium is no good. You shouldn't have any. You should have a 0 calcium score. And the lower, the better. So now with the calcium scores, it's the most predictive of how long you're going to live. Very predictive. If your calcium score were high, you would have come to this, either with the CT scan or the cath lab or a nuclear stress test. Calcium score is so low, you don't need all that. It's not encroaching onto any of your artery lumen. It's not narrowing down your artery. So you're very fortunate. Now, those who have a high calcium score, we don't just do one study. We do one now, we do another one within 2 years. So let's say that your calcium score today is very high. Let's say it's 1800. And then 2 years from now, your score comes back at 1850. It's gone up a little bit. It's gone up by less than 10% in 2 years. That's good. But if it comes back now at 2100, you're cooking. So this person there, he's going to come in and we're just going to open him up completely. I want to know everything about you. Where are you living? What you're doing? What's your lifestyle? What you're eating? What time do you go to bed? What time do you wake up in the morning? What are your stools like? I'm a cardiologist. I want to know what your stools look like. Describe them to me. How often do you have a bowel movement? What causes gaseous distension? Let's look at your metabolites. Let's take a look at your heavy metals. Do you have, you know how many people have heavy metals? Mercury, lead? I never thought this was important as a cardiologist. But I'm finding that these patients are toxic. Heavy metals cause atherosclerosis. So I look at that also. Then I'm going to look at your liver, look at your insulin levels, look at your sugar levels. You're very fortunate your calcium score is so low. Now, you still have to be careful so that you don't develop more calcium in the future, and also make sure that you don't develop the other illnesses that people get. Because just because you spared your coronaries, are you going to spare your brain? What's worse than a heart attack? Heart attack, I'll come fix you. Who's going to fix your brain if you get dementia? Or a stroke? And dementia. I don't believe that dementia is just dementia. Dementia is vascular. It's vascular. And a lot of dementia today is inflammatory. So it's all to do with blood vessels. Every organ is as good as its blood supply. That's a golden statement. Every organ is as good as your blood supply. You want to have excellent organs in your body, you make sure your blood vessels are good. That's a golden statement. Nobody believes. You see what's happened is that we are all so insular. We think about each organ individually, and every doctor looks at his own organ. I say that the biggest organ in the body is your blood vessels, your endothelium. You want to keep your liver healthy, give it good blood supply. You want your intestines, your brain, your eyes, your heart, everything. Give it good blood supply. And basically it comes down to this. Making sure that all your blood vessels are good. They vasodilate properly. ED, it's all blood supply. It's all the blood vessels dilating or not dilating appropriately. It's all to do with blood vessels. So it's very important. So yeah, you may dodge the coronary bullet. Make sure you don't die from one of the other bullets. You see? Yeah. And I'll take it even further. That even a lot of the cancers are driven by metabolic disease. They're driven by metabolic disease. So, if your calcium score is 0, you're good for 5 years at least. But if your calcium score is less than 100, I'll do it in about 3 years. If it's more than 100, at least every 2 years. If it is very high up, probably for the first couple of years, do it every year. Because I want to know how steep your curve is. And get aggressive. Get aggressive. You're not going to get rid of it, but it's an indication something's going on. I need to find out what is it. What is it in my physiology that I'm cooking? Why am I cooking inside? Yeah. Find it and reverse it. So, and in a nutshell, the bottom line is pay attention to what you put in your mouth and how often you put it there. Yeah, very good question. So what makes it crack? You're saying what made that plaque crack? I'm going to draw you a plaque and then I'll show you how it cracks. So this plaque has a thin capsule over the front, thin layer. This is called the endothelium. It's a thin single layer and it is protected by the glycocalyx, which is like little hairs. And this layer is a thin layer, monocellular layer like that. Behind this plaque, there's this buildup here, and there's some buildup here, right? So you're saying what makes it crack? I'm going to show you. At the edges here are T cells and B cells, are inflammatory cells. They are inflammatory cells because they're going after something. And in here, fat globules. Where did the fat come from? The fat came from white cells, macrophages, and they saw that LDL particle, the small dense particle, and it's full of fat because it's got cholesterol in it, but it's also got that LPS on it. So that's a deranged particle. So this white cell comes, it gobbles it up. I drew it out of scale. This is supposed to be much bigger. It gobbles it up. So now you have all of them in here. And when these cells come here and they're attached here and go inside here, they die in here. And all the calcium is here and the fat is laid out. So it's all here. And these are the foreigners. The cholesterol is not the cholesterol you ate. The fat that's in here is not the fat that you ate. It's the LDL, cholesterol. But it's not because your cholesterol level is high. It's because your LDL was deranged. It became abnormal. Why? Because of inflammation in the body became small, dense. That's why we do advanced lipid panels. I don't do total LDL. Because a total LDL does not predict who's going to get a heart attack or who's going to get a stroke. It doesn't. 50% of patients who come to the hospital with a heart attack have normal LDLs. But what you should be looking at is your small, dense LDL. And you can only get that on the advanced lipid panel. So most doctors don't even order advanced lipid panel. You have to order an advanced lipid panel to know whether you have small, dense LDL or not. Because that's inside the plaque. Now, this all in here, there's a war going on in here. So these T cells and B cells are producing substances that dissolve the tissues in here. They are called matrix metalloproteinases. So they're dissolving, just like how when you get an infection, you get a hole. When you get a pus comes out and there's a hole left behind and everything is liquefying, right? It liquefies the tissues in here. So the matrix metalloproteinases, they degrade the materials inside in an active inflammation. So this thing will burst because if there's a thin cap, this is called a cap. If it's very thin and weak, it will burst. And when it bursts, the blood that's floating inside the blood stream sees it and opens up. So what makes this inflammation? That's active inflammation. Now, if you have a stable plaque with no inflammation going on in it, it'll just be full of calcium only. There will not be inflammatory cells here, nor will there be much fat there. Because it's old history now. You just got calcium. Hopefully people have mostly just calcium left behind. I don't want to see inflammation. The question is, how can you tell if there's inflammation in there? Good question, right? How do I know that you are this with inflammation versus another guy who's got this and all it is just calcium? How do I know the difference? There is a test that you can do. It's called the plaque differentiation. You can actually, on the CT scan, see where you have only calcium and where you have calcium and fat. But we haven't perfected it yet. It gives an indication of the ratio of how much fat and calcium you have and how much just calcium you have. When I was doing my research in my old days, I would take a wire, a temperature wire, and I'll pass it along the artery. And when the temperature rises, there's inflammation in that plaque. And also there are certain imaging techniques that you can use where you can actually shine light up into the walls and get a optical coherence test, and you can actually see if this plaque is inflammatory or not. You get some ideas on that. But we haven't perfected that science to the point where I can say to you that, oh yeah, you got a plaque over here, and yeah, it's perfectly okay, you're going to be all right. No. Instead of looking at that in this way, what I look at is your markers, your HS, CRP level. Is it high or low? If it's high, your plaques are probably inflamed. If you have small, dense LDL, your plaques are inflamed. If you have a high insulin level, high sugar level, these are all indications that your plaques are probably very inflamed because you have inflammation going on. So individually, I can't go to your plaque and tell you whether your plaque is inflamed or not, but I can do blood tests on you to see what's going on. And number two is I can repeat your calcium score in a year. If it's going up, then they're all inflamed because they're growing. They're growing. Stable plaques don't grow anymore. So if your calcium score is going up, you have a problem. If your CRP is up, that's C-reactive protein. If you have small, dense LDLs, if you have high insulin levels, high sugar levels, all these are blood tests that we can do to give us an idea that you are inflamed, therefore your plaques are inflamed. Yeah, one day I hope we have a test where we can inject something into you and it will light up this artery and show me this one's hot, this one's cold. So this one is very active, this one is not. But then let me ask you a question. Since you asked this, let's see if you can answer this. Here's an artery, and you've got a blockage here of 30%, and it's just calcium. This one is 30%, but it's very active. What are you going to do with that? It's not limiting flow. So you see my point that if you have inflammation in the plaque, what's the treatment? It's still systemic. You need to treat the whole patient. So even if I find a plaque that's hot, if it's not obstructing, I'm not going to stent it. If the FFR on that plaque is good, I'm just going to leave it alone. What I'm going to do is chase you systemically. Whole of you, I'm going to treat the whole of you. From the morning you wake up to the time you go to bed and what type of sleep you have at night. Everything will need to be evaluated and changed because you are inflammatory. So inflammatory plaques require a systemic treatment, not a localized treatment. A localized focal lesion requires a localized treatment. Okay, so that's a very good statement. I'll repeat it again. A localized focal lesion that is hemodynamically significant requires a localized treatment. Put a stent in it or bypass it. All other plaques require systemic therapy. Coronary artery disease is a systemic disease. Take that to the bank. Coronary artery disease is a systemic disease. It can have local manifestations too, but it's really a systemic disease. That's a whole new paradigm of thinking that it's a systemic disease, not just a localized disease. It's also occurring in your brain. It's occurring in your carotids. It's occurring in your iliacs. It's occurring in your kidneys. So it's a systemic disease. And that's how we got to look at it. This is systemic disease. Yeah. But it's a great point. But one day, we might be able to actually identify these more clearly. In research, it was fun because I'll put that slide by wire past here. The temperature would suddenly go up here, but over here it would be normal at 98.4. This would go up to 98.9 and then back to 98.4. They were hot. They were hot. You just open up a can of worms. Because I'm going to tell you it's not genetic. Less than 10% of all the diseases are genetic. But of course, everyone likes to think it's just genetic. No, it's not. It's epigenetic. Aha. What does that mean? You see, you just open up a can of worms. It's not genetic, it's epigenetic. Ultimately, all your physiology in your body is happening because of your genes, right? So it's not just the genes that you were given by your parents. It's what you've done to those genes because of your lifestyle, diet, mental and physical being. Mental and physical being that changes the expression of your genes. So your genes turn on and turn off. And which ones have you turned on? Which ones have you turned off? That's epigenetics. You see, from the time you were born to now, your genetic expression is totally different. This is a whole new paradigm of thinking. This is brand new thinking. People are getting to hear about epigenetics. Most people don't even know what epigenetics is. So they just want to blame their own genes. It's not that. Now, it may look like it's running in the families because if the families have the same lifestyle, the same diet, they live the same way, they metabolize the stresses in the same way, they eat the same thing, their lifestyle, then it looks like they're all getting the disease because guess what? The epigenetics are the same too. And this we know from twin studies as well. And they have perfectly same genes. But it's your genetic expression that changes. So I'm empowering you today to disempower genetics. Genetics is not what controls diseases. Its expression of disease is genetic ultimately because what happens is the genes are just there to translate proteins. They make proteins. But which proteins they're going to make, that instructions comes from you, the environment that goes in, turns and off and turns on certain genes. And then your nucleus is just doing what it's supposed to do. Oh, you want that protein? All right, I'll make it for you. And it makes that protein. So the answer to your question in a long and short is no, genetics play very little role in all diseases. All diseases. The science is telling us that this is mostly epigenetic. And that's in your control. You see, it empowers you. You're not a victim of your genes. But you created your epigenetic expression. You guys here love worms. But because that's the question I asked all my professors and nobody ever had an answer. But today I'm telling you that most of this inflammation is coming because of three things. I'm going to draw them for you. As a general rule, one is called metabolic endotoxemia. And that is coming from your gut. So I think bacterial wall products, you got leaky gut or you have wrong bacteria in your gut. So this is one, causes inflammation. Number two, your hormones are off. And that can cause inflammation in your body too. Inflammation is you're fighting against something. Right? You're fighting against something. What is that something? Where is that foreigner in you that it's fighting against that's causing this inflammation? Right? That's what you're asking. And then the third thing is toxins. Because your immune system is fighting against toxins in your body. For example, if I give you a lot of lead or mercury right now, your body is going to mount a reaction, or it's going to change its redox potential, and that's going to change a lot of your physiology in your body. So it's complicated. Because see, we only think of inflammation as infectious things that cause inflammation, like pneumonia or getting a big boil on your skin. But inflammation also because when your own physiology is changing, either because you have toxins or your hormones. So inflammation is a catch bag for a lot of things. It's not just bacterial or bacterial products. It's also your hormones, toxins, and you can also develop an inflammatory milieu if you don't have enough nutrition or the wrong nutrition. So, for example, if you have a lot of deficiencies in your body, your homeostasis is not going to be normal. So it's a complicated question. I will give you a separate talk on that one day. Yeah. But it's a complicated subject. But most of it that is actionable is check your gut, check your hormones, particularly insulin and sugar. Make sure you're not toxic. Make sure that you don't have, and by the way, it's toxin, not just lead and all these things. By toxin, I mean plastics. I'm talking about your makeup and your creams and all these estrogen receptor agonists, your soap, your shampoo. I don't need it because I got no hair left. No shampoo. But all these are plasticizers that get into your body. Antibiotics, they're a toxin. They're killing the bacteria in your gut. Artificial sweeteners, colorings, emulsifiers, preservatives. They're all toxins. They're not supposed to be in you. And they act through the microbiome. So you got to know all these things. You got to check for all these toxins in your system and get rid of them. And then your nutrition. Our food is so nutrient depleted. We don't have enough nutrition in our body because of the type of food. So we got to replenish our nutrition, get rid of toxins, fix our hormones, and fix our gut. A lot of things going on. A little complicated. Yeah. That's a great question. So far, I would say, I can't give you an exact number, but from the experience that I've had and from everything that I'm reading, it is at least 80 to 90% accurate. Because like I told you, only my wire is so precise that I can move it 4 millimeters and 5 millimeters and I'll get a different FFR. So it's very accurate in telling me exactly the location of the blockage. It's not that precise with FFR with CTs. It gives you more about that segment. See? And it is an evolving technology also. We're still learning about it. But the bottom line is, if you have an abnormal FFR on your CT angio, you're going to go in and look at the whole artery anyway. So you'll be able to see all those parts and stent only the ones that you see angiographically tight, but also corroborated with an invasive FFR. The technology is changing because the AI that we have today for this is going to be different another 4 years from now. It is changing very, very rapidly. So I think it's going to become better and better with time. And there's a learning curve for physicians, also for all of us, as to how we interpret these results. So, but it's another, you see, look, the bottom line is, the studies have been done that if you look at patients and you do the CT FFR, and it's not bad, but they have disease, they got calcium, and you just follow them for 15 years. How many? 15 years. The outcomes are good because they didn't have a very significant CT FFR. So a negative CT FFR is very helpful to me because it tells me that the studies tell me that I can leave that patient. I don't have to stent him. He's got a lot of calcium. He's got a lot of blockages everywhere, but none of them are tight enough. And if I just do my prevention program, they'll do better. And by the way, in those studies, you know what was the prevention program? Not much. They were giving them statins, basically, and get a little bit of beta blocker and a little bit of ACE inhibitor or something like that. Whereas today's prevention program that I do is much more than that. So I can expect even better results than that. So sometimes it's not the positive FFR that's going to help you, it's a negative FFR. You don't have. So leave it alone now. Let's just put you on very aggressive therapy. You should test for it anyway, now that the technology is. And I'm going to explain to you why. I'm going to explain to you why a patient who has blockages in all three arteries, the right coronary artery, the circumflex, and the LAD. Here's the heart. How can this patient who's got, let's say you do have an 80% here, 80% here, 80% here. Now, these are all significant. Am I right or wrong? But you're not having any chest pain because I told you 80% of patients never get chest pain. So let's say you do have these. Now I inject radioactivity into you. Stress test. You're going to get decreased flow here, here, and here. So when I look at the image, it's uniform. But let's say you did not have this one here, and here there was only 10%. You would see decreased flow here, good circulation here, decreased flow here on the image. You say, you failed your stress test because you have decreased flow here. But when all three arteries are down, you're going to get uniform decrease in flow. So you're going to see what I call homogeneous decreased uptake of radioactivity. There's no heterogeneity. Because the way you interpret a nuclear stress test is you're looking for heterogeneity. Heterogeneity means one part of the heart getting lots of radioactivity, one part not. Well, how come this part's not? It's got a blockage there. But if all three have a blockage, there's no disparity. You got it? So this is very important for patients to realize that if your calcium score is very high, and if you have blockages in all three arteries, you can get a false negative nuclear stress test. That patient, if it's young, calcium score is very high, just do the CTA with FFR. Because you don't want to be caught with somebody that has very high-grade blockages in all three arteries that gave you a false negative nuclear stress test. So a lot of judgment is needed there too. But with such a high score, negative nuclear stress, probably okay because your functionality is still important. You're able to get around, climb Mount Dora and come back, no problem. But to just make you feel better, you should do a CTA with FFR. Now, when we send up these studies for FFR evaluation, some segments, if the vessels are too small or too thin, they cannot really adequately analyze those. So it's not always the case that you're going to get every segment of your artery analyzed. Sometimes they can't analyze some parts. So there's some technical issues as well. But generally speaking, most of the time you get a pretty good reading. You can see everything. It's another tool in our armamentarium to hone down on who's the troubled kid on the block. I don't need to worry about these guys, but that guy there, I need to worry about him. Get him in there. I might even cath him. Become more aggressive. More information, the more I can hone in on that guy. Like I said, If the FFR is fine on that other patient, even though he's got a high calcium score and it's been stable now for 3 years or 4 years, I can sit back. My data shows me he's going to do fine. He's going to do all right. See? So those studies have all been done. We do know that a negative FFR is a good thing. Yeah. Okay. Well, thank you for coming out tonight. Thank you, and drive safely.
Okay.
If you liked this video, here's one that I would recommend. And if you want to see my latest video, please click here.